Next video here is going to be about hepatic disorders. So let's get into that. Just as a review, a little anatomy and just some general kind of concepts, get you thinking about the liver again. It's actually considered the largest gland of the body. It's just large, it's considered a gland because it does secrete. It's located primarily in the upper right abdomen, does extend across the central portion of the abdomen, just above the umbilicus, in the gastric region. And you'll remember that from CPR. This is an important takeaway, is the liver is a highly vascular organ. Now, that's going to make a lot of sense when you think about it, because the liver's primary function is bioconversion of any chemicals we consume in order to have an effect in the body. So drugs, other chemicals that are consumed through the gastrointestinal tract, and also conversion of food that we consume into producible, usable energy. So there's, a process there that the liver goes through to bioconvert the things we consume in order to make them functional and operational in the system. It also serves, as we've already discussed, so this is a great time to kind of touch on liver. You're going to find me calling back some things we've talked about from already in class, but it serves the purpose of providing carbohydrates for us in the absence of food. So in the fasting state, you'll recall that the liver is responsible for gluconeogenesis. So that all those things being the case, there needs to be a high degree of vascularity going to the liver. Most of it is venous, as you can see, 80% of it through the portal vein. Portal vein, that's going to be important to remember, because that creates some of the most critical problems that are related to liver failure. So 80% of that blood flow that's going to the liver from the gastrointestinal tract is going through the portal vein. And then another 20% through the hepatic artery, which is where the liver gets arterial blood or oxygenated blood in order to perfuse the organ for it to have its function. Basic structure: capillaries dump in the capillaries within the liver dump back into the sinusoids, the Kupffer cells, which then dump into central veins back to the hepatic vein and then to the inferior vena cava. Is the way the blood returns from the liver into central circulation. Then waste from the liver is deposited into the small bile duct, which then is housed in the gallbladder, where it's, bilirubin, bile salts, fatty acids, sodium, potassium, all that is combined together to help emulsify and break down those components so that they're prepared for elimination through the gastrointestinal tract. Unless there are things there that need to be absorbed. And then that bile then empties from the bile duct into the duodenum and is reabsorbed in any liquid there, and certain nutrients are reabsorbed through the ileum, and then subsequently waste material is excreted in the large bowel. This is a cross section, just a visualization so that you can see those structures we just discussed. You can review that in your own time. This picture is just to kind of give you an overview of the anatomy. So when you're looking at a human being, you have an idea of how things are situated in the human body. So you can see where it sits in the abdomen and how it's connected to other structures anatomically. So metabolic function, liver primary functions are glucose metabolism, of course. We've talked about this already, glycogenolysis and gluconeogenesis. So that's that process of providing glucose in the absence of carbohydrate consumption or in a fasting state. Also converts ammonia. So amino acids get processed for gluconeogenesis, but that process then converts ammonia to urea in the liver so that urea can then be excreted and eliminated. So we've talked about BUN, blood urea nitrogen. Urea is that uric acid that is a process of amino acid metabolism. It's a byproduct. I mentioned that earlier. It's a byproduct of protein metabolism. So obviously, the higher proteins in your diet, the more urea you're going to be making. And provided normal kidney function, that should stay relatively constant in a normal range. The liver also does synthesizes proteins, an example being vitamin K and other coagulation factors. This is important. So in addition to the things we've already mentioned, I mean, really, it's kind of all important when you think about the liver, but it's important to note this because when you start getting questions about a patient's bleeding issues, there are a few things you should start thinking about just automatically. One is an electrolyte we've already talked about. So you start talking about bleeding issues, you should be thinking about calcium right off the top. That's the electrolyte plays a key role in the coagulation cascade. Then when you start thinking about the liver and coagulation, you should be thinking about clotting factors, vitamin K and the other clotting factors such as fibrin, fibrinogen. Those are other components of the coagulation cascade, and you've got to have them in order to make clots. So if you've got liver problems, then you're potentially going to have bleeding problems. And if you have bleeding problems as in blood that's not going to coagulate, so if you also have calcium deficiencies, you're also going to have another factor contributing to coagulation or the lack thereof. And you remember that calcium is important in the liver as well. So that's an important component there to lock down. We've already discussed fatty acid metabolism. So this is just a callback to the things we've discussed when we talked about insulin, and that when the liver metabolizes fats, it breaks them down into ketones that produces energy in the form of carbohydrates, but it also produces ketones and acid. So those fatty acids also get formed into cholesterol. One of the liver's functions is to assimilate fatty acids, triglycerides, and compress them into cholesterol and store them, and store fat as adipose tissue. So remember I said at the beginning of this, the liver bioconverts basically anything we consume. So glucose, proteins, and fatty acids or fats. You see here, it's also responsible for vitamin and iron storage, bile formation. We were talking about that just a minute ago, that as the liver processes things, those bile salts get compressed and deposited into the gallbladder from the emulsification of fats, as well as other byproducts from the breakdown of hemoglobin and red blood cells and the formation of bilirubin. So all of those things together, comprise what we refer to as bile, and contributes to our stool composition. It is also responsible for drug metabolism. I alluded to this just a minute ago. So anything we consume as a chemical that we expect it to have a function or an effect in the body, it has to be bioconverted and bioprocessed in the liver in order to be effective. And that's what we refer to as first pass metabolism. There are several routes here, ways we can bypass first pass metabolism, because sometimes people have liver issues, or we need the drug to be active in a form that's not bioconverted, biotransformed by the liver. So things like sublingual, buccal, those are similar, buccal being in the cheeks, sublingual under the tongue, rectal, IV, transdermal. All of those routes bypass first pass metabolism. So we're looking at drugs that are moving into the system and being effective in their original form. And then, depending on how they move through the system and how they're metabolized or excreted, they may then return later for other active metabolites. So drugs, however, that are absorbed in the gut are biotransformed by the liver, and that's what we refer to as first pass metabolism. Now, when you talk about metabolism, you should also be thinking about metabolites. I've mentioned this to you already. as you guys were preparing for clinicals, I asked you to look at medications and see if those medications have active metabolites. What that means is, a good example of this is Ativan or lorazepam, that when you take Ativan or lorazepam, that drug moves into the system and has that effect of the benzodiazepine. However, once it has been biotransformed and undergone first pass metabolism, as it circulates in the system, it also has other metabolites that have effects in the body. I'm going to give you some examples of that, but they have effects in the body that contribute to the overall impact or action of that medication in the human system. Some of this explains side effects. It contributes to half-life of that drug and the half-life symptoms or manifestations effects that extend beyond just the half-life. So that it kind of can explain some of that. So let's look at a couple of examples, things perhaps with which you may be familiar or you may have heard of, and of course they may be new to you. But I know you all are familiar with caffeine. Caffeine is metabolized by the cytochrome P450 process in the liver, and caffeine itself is not the active component, so it's actually the active metabolites that produce the symptoms that you experience. So things like paraxanthine, theobromine, and theophylline, those are the components that create the sensations of jitteriness, tachycardia, if your blood pressure goes up, that sort of thing. All of those active metabolites produce those symptoms. Now, the effect of caffeine waking you up is produced as a result of things like paraxanthine, which also contributes to the diuresis portion. But paraxanthine and theobromine bind adenosine receptors in the brain, and that basically inhibits sleepiness and what creates the experience of feeling more alert. So it inhibits the sleep cycle, the sleep system, and makes one feel more alert. So you can see how active metabolites play an important role. Now, thinking about metabolites and half-life, a good example here of way that is pretty dramatically different between a couple of antidepressants is think about medications like Prozac and Luvox. Prozac is an older antidepressant. Luvox is one of the newer ones in the system or out there on the market. And similarly processed by cytochrome P450, but Prozac itself is listed a 60-hour half-life, which is long enough as it is. That's several days. But notice that when Prozac is metabolized, it's metabolized to norfloxetine, which basically is active on receptors for 120 hours. So the half-life doubles based on the active metabolite of the drug. This half-life, together with this extended period of time, speaks to or helps underscore the importance of taking the medication for a couple of weeks before you really start seeing the full effect. And two, when someone is stopping one of these serotonin reuptake inhibitors, they need to taper off of that medication because this half-life is so long. There's adverse side effects that result, particularly serotonin syndrome, from an abrupt departure from the medication because of these very long half-lives and these active metabolites that result from that. Notice that Luvox has a much shorter half-life. There are no active metabolites from Luvox. So the point is it moves into the system more efficiently and also clears out of the system more quickly. So when you stop the medication within approximately 15 hours or so, obviously that's going to depend on how long you've been taking the medication, but in approximately 15 hours, you're going to have eliminated majority of that medication, its effects, and there are no metabolites that are resulting from that, the metabolism of that medication. So a drug you may be more familiar with is morphine, which morphine gets listed as a 3-hour half-life. There are 2 compounds that contribute to the effects of morphine. So 3-glucuronide is one of the compounds that morphine is metabolized to that causes some people to have the experience of having hallucinations or agitation. 6-glucuronide has a 5-hour half-life. So once morphine is metabolized to 6-glucuronide, you've got 5 hours of expression of the effects of that medication, which is analgesia, which is one of the main benefits of the opiates, specifically morphine in this case. Now, sulfentanyl, or you may have heard it called fentanyl, which is the trade name. Sufentanil is the chemical name, has a 2-hour half-life, but also has no active metabolites. What that means is when you give fentanyl, you have an effect and you have a time frame that you know that drug is going to have an effect on this individual. So if they're going to have respiratory depression or something like that, most typically it's going to be within that 2-hour, or maybe slightly above that if they're very sensitive, around a 2-hour window. What that also means is they're not going to be as sensitive to respiratory depression after that, because there's no byproducts of this drug's metabolism in the system like with morphine. So that means a medication like this can move into the system quickly, move out of the system quickly, and you know there's very little repercussions going forward. This is one of the reasons why fentanyl is used a lot for analgesia in outpatient procedures or conscious sedation, because the effects are on and off, and we're pretty much done with that by the time we're finished. So that can be one of the great benefits of fentanyl. Now, because of the nature of the way fentanyl works, it does have a higher association of respiratory depression part of it, because so much of it does move into the, so much of the dose moves into the system so quickly. So a question here, why does liver function and kidney function matter so much? This should be somewhat clear after what we've talked about to this point. They essentially feed into each other. The liver is metabolizing the drug, and the kidney is clearing the drug. Those two work together for a drug to reach its peak onset and action, and yet also be cleared so that it sufficiently moves out of the system in an appropriate time frame. So they actually work in concert with each other. The kidney, the liver getting the drug in an effective way into the bloodstream, and the kidney, as it's appropriate and over time, clearing this drug out so that we're either ready for the next dose or we've done what we've needed. We don't need that drug in the system anymore. So you can see then why liver function and kidney function can, I hope you can see the impact that can have on medication effects in the body. So if you have poor liver function, then that drug may be poorly metabolized. It may be metabolized very slowly. The active metabolites may take longer to be broken down, and that can mean the drug is longer in the system. If you have poor kidney function, but your liver's okay, it may mean that the kidney's not clearing those drugs, and those drugs stay in the system longer. If you have both, we have to consider titrating or adjusting dosages so that we don't give patients too much of what would be normal for someone with normal kidney and liver function. There are several liver function studies out there with which I'd like for you to be familiar. Not that I necessarily want you to remember all of the ranges for these tests, but there are tests that when you see them, you should recognize that they are telling you about liver function. Those are the serum aminotransferase tests AST, ALT, GGT, GGTP, and LDH. Those tell you specifically about liver function. So when you see a liver profile, you're going to see these tests ordered. And conversely, when you see these tests ordered, that should be a tip-off that your provider is concerned about liver function on your patient. Now, protein studies are not necessarily specific to liver, but the liver is highly responsible for protein metabolism. So protein studies such as serum protein, albumin, that sort of thing are going to be reflexive of how the liver is functioning. Now, byproducts such as bilirubin, urine bilirubin, and urobilinogen, those tests are both indirect and direct bilirubin. Those tests are going to be indicators specifically about liver function. So again, when you see these, bells should start going off that your medical team is concerned about liver function on these patients, or if you're concerned about liver function, these are things you should be raising the flag to your provider to say, hey, let's get a liver profile. Let's get some liver studies and see what's going on here. Now, some others that are associated with liver but may or may not be directly related to liver function are clotting factors. There are a variety of things that can affect clotting factors. Liver is definitely one of them. So if you have liver problems, you definitely want to do clotting studies. Now, just because clotting studies are done doesn't mean the patient has liver problems. So that concern goes one way, but it's still noteworthy to think, when I see clotting factor studies done, is my liver function okay? Especially if those clotting factor studies are abnormal. So these are things like fibrin, fibrinogen, fibrin split products, PT, PTT. All of those are clotting factor 10A. All of those are clotting factors, and the liver plays a huge role in forming those clotting factors in addition to platelets. So when you see those, we definitely want to do those tests if a patient has liver compromise of any fashion, but also be aware that there are other conditions like leukemias and things like that that can affect clotting factors, and conditions like DIC that can affect clotting factors also, that aren't necessarily related to liver dysfunction. Serum alkaline phosphatase, that is another test that can be associated with liver function studies, as well as serum albumin and lipids. So table 43.1 kind of gives you more of a breakdown on some of that if you want further information. I don't care that you know all of the normal ranges for these, but you do need to be aware of what these tests are telling you so that you understand that we're concerned about liver function. So you definitely should know about bilirubin, both direct and indirect, clotting factors, and ammonia. You should definitely have those connected with liver function, because serum ammonia, as ammonia levels rise, if you've got liver function, that's going to contribute to a decrease in level of consciousness. That's something you need to be dialed into. Interpreting AST, ALT, GGT, and all of that, that can get quite intricate. We don't have time to get into the granularity of that. This slide gives you an overview of what those aminotransferases do in general, and you can see as you look at this that there's overlap. Multiple of these are affected by cirrhosis, for example, or alcoholic liver disease can affect almost all of these. Severe hepatitis and or severe liver failure, you're going to have elevation of all of these. This slide just gives you kind of an overview of those different tests. Now, in addition to the chemical profiles that I just described, if those indicate that we have liver problems or things that are concerning for the liver, we may not be able from history alone to be able to come to a clear diagnosis of what's caused this problem. A good example is alcoholism versus NASH, non-alcoholic syndrome of hepatitis. Those two conditions both look like alcoholic liver failure. And sometimes people are not honest about the alcohol they consume. That being the case, you have someone who presents with what looks like alcoholic liver or liver failure as a result of alcoholism. They may look the same. And even as we talk about in a little bit, someone with severe gallbladder disorder or severe cholelithiasis may also look as though they are in liver failure. And the studies may all be abnormal and look similar to the profile that you might see with alcoholic liver issues. So when you have that scenario presented and the patient is perhaps not trustworthy, or you question whether they're being fully honest about in full disclosure about their alcohol consumption, we may have to do more provocative studies, and this is a list of some of those. First of all, we're going to start with tests that are less invasive. So the non-invasive studies here are ultrasonography, CT, and MRI. They are a little more specific as they get more expensive, I guess you could say, but as they get more complex. So let me talk about those three first. An ultrasound of the liver basically allows the sonographer and the physician to see structures, size, shape, configuration, vascularity, gallbladder, etc., the structural portions of the liver in a superficial way. CT allows a more penetrative, non-invasive view that helps look at those structures to look at things like abscess or perhaps a full and distended gallbladder, or things that look and appear like gallstones. Those things can show up on CT scan and might be ambiguous by ultrasound. Now, MRI gets a little more granular and more specific because it's really good at looking at soft tissues, and it may be able to give us a little more granularity, a little more detail, non-invasively. And of course, CT and MRI we can both do with contrast to help further augment that visualization. Once we've gotten some of these non-invasive tests done, that still may not be clearly indicative or may actually illustrate the need for something invasive such as a liver biopsy. That may require that we go in under ultrasound or CT guidance into a portion of the liver and actually take portions of the liver and send it to pathology for someone to look at the tissue under a microscope, a pathologist, and make a fairly definitive diagnosis on what is going on with the tissue. There's some additional information in chart 43.3 if you want to review that. I just want you to be familiar from our perspective. I want you to, class perspective and test perspective, I want you to be familiar with the progression of these tests and which ones are invasive and non-invasive. Because think about this, it's important to know the liver biopsy is invasive because why are we doing this test? We're doing this test because we've got liver problems. So if you got liver problems, you're likely to have bleeding problems. So now we're going to go take tissue from a highly vascularized organ in a patient that may have coagulation compromise. So liver bleeding can be a big issue here. All right. So when we talk about hepatic dysfunction, generally they fall into two categories, acute or chronic. And acute or chronic cirrhosis of the liver is one. You can have acute on chronic, where a patient has got chronic liver failure or liver cirrhosis from a lifetime of alcoholism, and then they have an acute exacerbation. And that's what we refer to as acute or chronic cirrhosis. Now, often cirrhosis can be caused and is caused by alcohol use. So there's a direct connection to liver failure associated with alcohol use. That's true. However, cirrhosis can happen from other causes, such as viral mediated infections and things like that, such as hepatitis, which is an actual infection of a virus that affects the liver. There's also two non-alcoholic fatty liver diseases, non-alcoholic fatty liver disease, and then non-alcoholic steatohepatitis or syndrome of hepatitis. You'll hear it referred to both ways. So these are the general, the largest contributors to hepatic dysfunction. And of course, chemicals can do this too. So there are drugs, we've introduced some drugs and talked about some drugs through the semester that can contribute to hepatic dysfunction and cause liver failure. So it's good to remember that when we start talking about hepatic dysfunction. Now, across the board, when you have hepatic dysfunction, the manifestation is going to look fairly similar. One of the most common symptoms associated with liver failure, regardless of the cause, is jaundice, the discoloration of the skin, the conjunctiva of the eyes, the urine ultimately, and other body fluids all have a yellowing appearance. Another effect of liver failure, in addition to jaundice, is portal hypertension. You'll recall earlier in this presentation, I mentioned 80% of the blood flow flows through the portal vein. If you have a liver that is resistant to perfusion, resistant to that low pressure blood flowing into the liver to be metabolized, if you have resistance there, that is a low pressure system that's not accustomed to having back pressure from the liver. So that creates what is called portal hypertension. So hypertension in the portal vein, not the hepatic artery. We have to be really judicious in trying to manage portal hypertension because it can be very problematic, because that is commonly what contributes to the next item here, which is ascites and varices. So ascites is the accumulation of fluid in the abdomen, usually as a result of liver failure. This excess fluid as a part of the plasma that's backed up in the portal system looks for a place to go. So it looks for a place of lower pressure. And as well, the proteins that are moving into the blood, that are trying to move to the liver, are going to be looking for a place to go because they don't have an outlet to be metabolized, to be actually moved into a useful structure. The fatty acids can get stored as fat, and the carbohydrates can be easily metabolized for energy. The proteins have a more complex breakdown, so those proteins then can get shunted into the peritoneal space, and those proteins resting in that peritoneal space then draw fluid by osmosis into the spaces around the tissues of the abdomen and produce what we refer to as ascites. Now that pressure also in that vascular space as it produces ascites can also put pressure on these low pressure structures around the stomach and esophagus. And those vascular beds are not used to that pressure, and that can produce what are referred to as varices, the singular of that being a varix, and that can create severe bleeding issues. Another side effect of this process that is directly related, because it's connected to protein metabolism, if those proteins are not metabolized appropriately, then ammonia can accumulate, and as the ammonia levels rise in the human, then consciousness goes down, and that, as a result of hepatic dysfunction, is referred to as hepatic encephalopathy, and can result in listlessness, decreased level of consciousness, and ultimately coma. And depending on the severity of the encephalopathy, depending on the severity of the liver failure, may or may not be reversible. That is going to vary depending on the acuity and the gravity of the patient's situation. As you can imagine, if the liver, all of this taken together, if the liver's not functioning well, if it's not functioning and metabolizing proteins as well, we may be able to use carbohydrates, but we may not be processing them as well. We may not be processing fats as well as usual. That can contribute to nutritional deficiencies. Now, the other component to that is one of the big contributors to liver failure is alcoholism. And most alcoholics, when they're getting to this point, they have such a habit that they're getting a majority of their calories from alcohol. So that contributes, it makes a huge contribution to the nutritional deficiencies there. Jaundice, as I mentioned just a minute ago, is this yellow discoloration, and that's secondary to the accumulation of bilirubin. So it affects the sclera and conjunctiva of the eye. It affects the skin and also urine and other body fluids. And some of these patients that have severe liver failure, basically any body fluid that comes out of them is going to be the same color. Essentially, hepatocellular and obstructive jaundice are most associated with liver disease. There are some others down here I'm going to talk about in just a minute, but hepatocellular and obstructive are most commonly associated with diseases and processes problems within the liver itself. When you begin to see jaundice, that is a pretty good indication that your bilirubin levels are going to be in excess of 2 milligrams per deciliter. So they may even be higher than that. But when someone walks in and they're already jaundiced, that's going to be kind of give you an idea where their bilirubin is probably going to at least be. Now, the hepatocellular is when we're talking about damage to the cells themselves of the 4 types here that I've got listed. So that's where viruses, toxins, and think about drugs as toxins. Even though they're pharmaceuticals, they, in some patients, if they're causing cellular injury, then we refer to them as toxins. That's what we mean by hepatocellular injury or hepatocellular liver failure. Obstructive has to do with issues such as gallstones that block or occlude, fill the gallbladder and or the gall duct and produce an obstruction. So that means the bilirubin cannot leave the body through its normal mechanism, through the the bile duct, gallbladder, and so subsequently the stool. That could also be a tumor, inflammation of the bile duct, pressure from a tumor in another location, or some other type of structure that's putting pressure on the bile duct. But remember sulfonylureas. I talked about those drugs earlier in our conversation when we were talking about anti-diabetic agents. The sulfonylureas can also produce an obstructive liver failure. So all of these things look like liver failure, but the cause is a little bit different. Phenothiazines, one of the side effects of that drug, along with tricyclic antidepressants, can also produce that. So I'd like you to be familiar with those 3 items because they will come up. Tricyclics are still out there in use, not the common or best practice for the treatment of depression and anxiety, but you'll still see tricyclic antidepressants used. And then there's also hereditary hyperbilirubinemia, which is a hereditary condition that will present itself rarely. I don't know that I've ever cared for a patient with this. So it does appear, but it's not one of the most common causes. And then hemolytic liver failure is another problem. And this is where basically the liver as a filter gets all clogged up with the byproducts of hemolysis. So red blood cells have been lysed for whatever reason as a reaction to a medication, as some other form of disorder. This is potentially an outcome of sickle cell if it is allowed to persist and remain serious and become serious enough, left untreated. Also, rattlesnake venom, for example, is a hemolytic venom that can produce hemolytic liver failure. as well as some of the effects of a gastrointestinal E. coli infection, like some people have gotten over the years from different foods not being prepared appropriately, whatever, can cause hemolytic reactions where the red blood cells lyse and produce a liver failure. So we're going to pause the button here, and then the next video we will discuss portal hypertension and ascites and esophageal varices.